Hello, my name is Cheryl Fatideni, and I am the Chief Nurse Practitioner Officer at the NNCC. And on behalf of the National Nurse-Led Care Consortium and the AANP, I would like to welcome you to today's Lunch and Learn webinar, Medication Reconciliation for Nurse Practitioners. I will be moderating our presentation today, and I thank you for taking your valuable time to join us. Our presenter today is Kristine Gleason, the Regional Director of Patient Safety and Quality from Amita Health Adventist Medical Centers in Illinois. Today's webinar is being recorded and will be available in the upcoming week on our Nurse Practitioner Support and Alignment portal page, and a link to the recording will be sent to all registrants. All participants will be muted throughout the presentation. I encourage you to submit questions during the presentation. Please use the Questions tab on your GoToWebinar control panel as seen here to ask your question. It will be relayed to the presenters and answered at the end of the webinar. A survey will pop up at the end of the webinar and will be sent in an email later today. Please take a few minutes to complete the survey evaluating this activity, as your feedback is critical to the ongoing development and presentation of our webinars. The slides for today's webinar are available as a handout, which you can access via the Handouts pane in your control panel. You can click the name of the handout and it will be downloaded via your default web browser. Let me take a quick moment to talk about the national investment taking place for quality improvement in the United States with the help of our federal government and the organizations who are presenting this content as part of the Transforming Clinical Practice Initiative, which is sponsoring today's presentation. The Transforming Clinical Practice Initiative, or TCPi, is CMS's largest ever investment in practice transformation, with an investment of over $700 million over 4 years and an enrollment of 150,000 plus providers across the country. The NNCC, or the National Nurse-Led Care Consortium, is a member organization with over 250 nurse-led practices in our membership roster. Our mission is to advance nurse-led care through policy, consultation, and programs to reduce health disparities and meet people's primary care and wellness needs. Our partner in this initiative, the American Association of Nurse Practitioners, is the largest full-service national professional membership organization for NPs of all specialties. It is leading the way in advocacy, continuing education, and professional development for over 72,000 members. CMS has funded the NNCC and the AANP to support enrollment of nurse practitioners into practice transformation networks, or PTNs, across the country, and to develop NP-specific educational material that facilitates practice transformation in advance of the upcoming payment reform changes with CMS. The NNCC and the AANP are the only nursing-focused grantee of the TCPi project. The NNCC and the AANP agree that this initiative is important to ensure nurse practitioners receive the support they need to remain competitive in a changing healthcare landscape. NPs are the future of primary care in the United States and already provide high-quality and cost-effective care. This initiative is an opportunity for NPs to prove it by helping CMS and the broader healthcare community build the evidence based on practice transformation while preparing for value-based reimbursement. CMS is not funding this out of the goodness of their hearts. They want to use this program to prepare clinicians across the country for payment reform. In particular, payment reform under MACRA, the Medicare Access and CHIP Reauthorization Act of 2015. Many of you have probably heard of MACRA. It's legislation that was passed to establish Medicare's Quality Payment Program. Under this Quality Payment Program, there are two payment adjustment mechanisms to incentivize quality tied to Medicare Part B payments, MIPS, or the Merit-Based Incentive Plans, and Advanced APMs, or Advanced Alternative Payment Models. Most clinicians will end up associated with MIPS, or the Merit-Based Incentive Plan. The details of this aren't as important as the general trend. MIPS involves 4 elements that clinicians need to demonstrate successfully to maximize their Medicare Part B payments. These elements are to report on quality, to report on resource use, or the FFS, identify clinical practice improvement, or CQI, activities they are engaged in their practices, and how to use IT efficiently. Even if you think that MACRA and MIPS don't apply to you, if you can demonstrate these 4 elements in your practice, you can succeed in value-based payment in a value-based payment environment. The TCPi and their networks are meant to provide clinicians with the skills necessary to execute these 4 elements of practice. We know NPs have a large growing role in the delivery of health care, especially primary care. The NMCC and the AANP want to connect NPs to TCPi-funded practice transformation networks, or PTNs. These peer-based learning networks have the responsibility for enrolling and supporting clinicians. They provide free boots-on-the-ground technical assistance and services to help realize practice transformation. How can we as NPs help the PTNs by serving as leaders in their networks? NPs are more familiar with many aspects of the change package than physicians. NPs experience working in collaborative, interdisciplinary, and team-based environments. PTNs can provide NPs with nurse-led care centers with critical resources for practice improvement and access to larger networks of clinical peers. This helps to pull NPs and smaller nurse-managed health centers out of isolation. What drives the work of those in TCPi is the change package and its subsequent drivers. These drivers are a framework for us to use for the work that we do and are centered around 3 important areas of healthcare design and delivery. The first being patient and family-centered care. The second is continuous data-driven quality improvement. And the third, building sustainable business models. Today's presentation will focus on primary driver number 1, patient and family-centered care design, and its secondary driver of coordinated care delivery with the management of medication reconciliation. I'd like to begin our presentation today on MATCH, medications at transitions and clinical handoffs, medication reconciliation for clinicians. Our speaker today is Kristine Gleason. She is the Regional Director for Patient Safety and Quality at Amita Health Adventist Medical Centers in Bolingbrook, Hinsdale, and LaGrange, Illinois. She has 25 years of clinical pharmacy, patient safety, and quality experience in hospital and ambulatory settings, examining systems and errors, generating research and publications, and incorporating implementation strategies and change management principles for operational improvements. A significant focus has been on medication reconciliation, including the creation of the Medications at Transitions and Clinical Handoffs, or MATCH for short, TOOLKIT, which she has helped to develop through a grant supported by the Agency for Healthcare Research and Quality, or AHRQ. Kristine holds a pharmacy degree from Drake University and a master's in public health from the University of Massachusetts, Amherst. Kristine, I will turn the presentation over to you at this point.
Thank you so much, Cheryl. I'm really pleased to be here today. If you could advance the slide to the agenda, please. Thank you. I've really enjoyed collaborating with colleagues and educating and engaging patients about medication reconciliation. From my perspective, it's really an initiative with very broad, that has a broad impact. And I think it touches on almost all of the aims, goals, and drivers that the TCPi is trying to accomplish. So with that being said, I'm very pleased to be here and to be able to interact with you during this next hour. But we know for the content piece, I probably have roughly 30 minutes because we want to make sure we have time for Q&A. And so how do you approach a webinar with a very complex topic where we really only have a short time to really go through the content? I know many of the slides, as you've downloaded them, you might have noticed have been a bit content rich. That was purposeful to really serve as a reference. I also hope that you'll find the MATCH Toolkit helpful with, we feel it's chock full with a variety of examples, tools, sample work plans, etc. So for the webinar in itself, my assumption is that many of you are tasked, either directly or indirectly, to drive improvements within MedRec as part of the TCPi. Or you just heard about the webinar and feel very strongly about your individual work and how you might be able to improve that for the patients you serve. So with those things in mind, the agenda is very high level. We'll walk through some frameworks for how you can break down this complex process into smaller pieces so you can better understand where your vulnerabilities are within your practice settings. I've pulled together some conceptual frameworks and models just to think about, how would we address this in partnership with our patients and families. Although I feel MedRec is probably the highest priority, I know others and other colleagues that I work also have very important and relevant priorities and projects as well, not only with TCPi, but there's HIN work going on, which is another CMS initiative in the hospital setting. We're looking at cross-functional opportunities throughout the continuum. So with all that being said, I'd also like to explore how we can maybe bundle some of these elements together to create some synergies within our workflow. And then, of course, please, as we said, we're going to be holding questions, so jot down your questions and thoughts so we can expose those and kind of have dialogue during the Q&A, because I know I also learn as well. Next slide, please. So what is medication reconciliation? We probably all think we should know that by now, but I like to ground us in definitions. Once again, I think it's important we break down these MedRec steps into these smaller elements to make it a bit more manageable. I also think there gets to be confusion when people just talk MedRec, because as you know, it is a systematic process, but MedRec is also a unique step within the overall process. Within this framework, these big buckets that I think comprise MedRec, I feel there's two anchors, the verification piece and then the communication education piece. I feel both of these really hold in the success of the steps in between. And as we walk through the presentation a bit further, I'll explain why I think that's important. Next slide, please. So why medication reconciliation is a priority, and why is the TCPi kind of showcasing that is something we should be looking at. Next slide, please. I'm sure many of you remember back in 1999 when Institute of Medicine put his report, and I just remember the variety of kind of arguments and discussions both that I had in meetings and with colleagues and that you saw nationally about the numbers. Do the numbers, are they too high, are they too low? But at the end of the day, we have a repeat in 2013, once again quantifying some of those experiences, and we still know that preventable harm due to medical error exists. So I think regardless of the debate on the numbers, I think we all agree that one preventable medical harm is too many, because we know it could be someone's parent, spouse, sibling, colleague, friend. It could even be ourselves. And myself, who has gotten health care as a patient, can attest to how you're not thinking as a clinician. You're really thinking as a patient. And so I think we can all benefit for knowing that we still have a lot of work to do. Next slide, please. Within medical errors, we know that medication errors is a subset of that. So the IOM report also published an evaluation in 2006 looking at preventable adverse drug events. Even as soon as just about 6 years ago, the National Priority Partnership published a compact action brief as part of their roadmap for increasing value in healthcare, and they also noted that preventing medication errors is a $21 billion opportunity. So we know there's many ways to do this. We've had meaningful use with our EHRs. We're looking at how we can e-prescribe. We're looking at COPD. All of those are phenomenal to help push information, help give prompts and triggers at the time decisions are being made. But we also know there's a variety of non-technical elements such as communication and handoffs, and these are some of the things that medication reconciliation. Next slide, please. Many of you probably saw the recent publication in the British Medical Journal. This is just, once again, another visual of where medical errors fits. And when you compare that against other disease states, as well as areas of public health statistics, such as motor vehicle accidents, suicides, etc., once again, another visual and another reminder of the importance related to medication errors, and also knowing that 70% of our medical encounters involve some type of medications, hence the reason this is so complex. Next slide, please. So what have we learned? I did learn in my starting this back in the early 2000s that this is not a new problem. When I did a negative literature search, I saw lack of concordance, discrepancies from back in the 80s. So those folks maybe were pioneers when no one was paying attention, and they felt the importance of this. So I don't know that this is a new problem. What it has become is a much more complex problem as medication management has grown with technology and research and things that we've learned. Also, I'm not convinced in just some of the interactions that I've had just with family and friends that there's an understanding that our technology is not solving everything. I do not know every med you're on because I have an electronic health record, and you see that computer in the office or in the hospital. So I think there's how we can track our FedEx packages, to how we can Google things on Amazon, to how medications must work in healthcare. I think we have a lot to do too with partnering and educating our patients. So what we found in some of the steps that we'll share, and I had the opportunity to conduct probably over 100 patient interviews, conducting the MedRec steps, working with many organizations which I've been privileged to work with, that includes both ARC, working with Cheryl today and the work we've been interacting with over the last 2 months. Our QIOs, specifically working with iPro, who is a partner with us in the Toolkit, and others. We've had a few key lessons that we've learned that really help shape our Match Toolkit, and I'd like to kind of walk through some of those ones that really stood out today. Next slide, please. Our first learning was, as we analyzed we're in the process. A lot of those MedRec process steps, where did we find the most vulnerabilities as we walked through those and analyzed each of those steps? And we found that discrepancies most often were originating in histories and then carrying through as we went through the rest of the steps. So this was where my comment came in about how I feel like that first anchor, those two anchors, those bookends, if you will, about getting the important piece about getting our histories and validation. I feel like that's a really important one. And I'm sure we could have a webinar just to talk about how to get a good medication history, that's faith effort, and there's elements in the toolkit as well that we dive into that a bit deeper. And I'll share a couple slides in a few minutes about just some tips and tricks of where we may go with that. Next slide, please. Another high-level learning is that risk factors can be problematic of gathering medication histories. We know that, but they can be multifactorial. So for each unique patient, if we're really serious about patient-centered care, we need to create a very open, transparent, and comfortable environment so patients are willing to feel safe, so we can understand what some of those situations are and work towards corrections. Some of those that might be more difficult even for a patient to identify is low health literacy. And once again, there's a variety of tools and things out there, as well as some things in the MedRec toolkit that we can dive into how we would handle some of those. But once again, it's our job to make those conversations happen in a transparent, comfortable way. We also need to look at issues that aren't all the patients. We also have issues within our own health system that we need to look at, as well as as healthcare providers about how we interact and communicate. And that's one of the elements that I think MedRec helps to showcase as part of this multifactorial process. Next slide. Next slide, please. Thank you. Our third learning is that omission errors are probably the scariest, and those can often be the most frequent. They don't leave a footprint. So a med just drops off the list. Kind of that footprint is gone. A medication history, if you're doing like a longitudinal history, might help uncover why that happened. Good communication, I think, is key for why meds are changed or discontinued as we interact as provider to provider, as well as we have conversations with our patients in healthcare, in their healthcare, their care becomes the center of all of our encounters. And so how we develop that rapport and help them in having those conversations, I think, will be key. Also, as we look at our transitions of care, how we communicate is a whole other element of how we manage our lists electronically. And once again, that can be a whole other webinar in itself to dive into some of those elements. But once again, at a high level. Next slide, please. this is the one that I was most excited about. We talked to our blue in the face. Patients just carry a med list. Maybe they should, share their bottles. We actually found a significant protection, a statistically significant protection for avoiding medication errors when a patient presented with their own medication list. We did find that with medication bottles that were beneficial, although they weren't quite as statistically significant. We stressed the patients to carry their driver's license, their insurance cards. We should be addressing that is the most critical. And again, I myself have had several pretty serious medical encounters, and I consider myself a pretty healthy individual, only being on Synthroid. And I will tell you, I could not remember the dose of Synthroid for the life of me when I was being asked these questions. And I didn't have a medication list, because why would I? I'm a pharmacist. I'm presenting nationally on MedRec. I should be able to know what my dose is. So once again, how do we really prepare our patients for those encounters and help them to understand the roles where technology may not be able to play that role? And I think carrying a med list can be a key element, one of the things that we can accomplish as we look at education and patient engagement, which I know are other things that are being looked at within the TCPi. Next slide, please. So with telling patients to carry a list and their bottles and presenting that to us at every encounter, I want to say that's not the be-all, end-all. Even though that happened, as a pharmacist, were validating medication histories and doing MedRec as part of our research and understanding where the elements were, we still found errors, even when the physician or other providers looked at the same list. So once again, we can't just copy it verbatim. Mrs. Jones, you have a list, that's great. Are there any changes? Nope. Is this right? Yes, it is. That's great. I'm just going to go ahead and then I'll write your orders, or I'll use that to update the EMR in the office. We still need to have that conversation. We actually experienced a medication error where the provider saw metformin 500 milligrams times 2, the patient shortcut, and interpreted that as 1,000 milligrams twice a day. So once again, we still need to have that conversation, but this helps to advance our patients, get them more engaged, have them know we have an expectation they have that list, and that they present that, and maybe in helping them to translate what's on the right to what we would really like to see that's on the left. Next slide, please. This, once again, is that resource slide, very content heavy, but just to give you some tips and tricks, we actually, as part of our match, our core team, we stayed together for about 2 hours one day just talking about tips and tricks. And it was amazing. Folks brought up some things I had never thought about. So some of the things just to pull out that I think are important prompts are, one, like for instance, asking patients about meds they take less frequent. So that fentanyl patch they might change every 3 days, or a medication they may take once a month. Often patients don't think about those, or think about meds on their skin or other routes besides swallowing or maybe an inhalation. Often we might ask, have you had any changes, any recent changes, or are there any changes to that list that we said may not be perfect that we don't want to copy verbatim? Well, what does recent changes mean? Put those in a time frame. Recent to a patient might be in the last week. Recent to me as a pharmacist, knowing that a depression medication may take some time to see the benefit, might be in the last month, or I might want to know in the last month and a half. So once again, how we ask the questions might elicit very different answers. So those are just some tips and tricks that I found were really helpful in getting a more complete patient history. The next slide, please. So what do we do? Where do we go from here? So once again, because we have a very short time frame, I plucked out some of the conceptual frameworks that are in the Match Toolkit to help you maybe as you hang up on the call or as you talk with colleagues to think about, how do I even go about in solving this complex problem? I'm tapped as a TCPi champion to do X, Y, and Z. How do I even go about doing that? So I just would like to walk through some of the conceptual frameworks that you might find helpful to think how you want to tackle the issues, and no matter how broad or narrow you've defined as part of understanding the problem in your areas. And then hopefully you'll find that the Match Toolkit is one of many resources. There's some great work that's been done even since we've published our toolkit that will give you some tools and examples and more work plans and things that will help you be able to dig further into these frameworks I'll highlight today. Next slide, please. regardless of what you're working on, whether it be MedRec or others, I think there's some excellent guiding principles. Really understanding your roles and responsibilities. I think that becomes huge as practitioners. Who's doing what and when? What's the patient's role and responsibility? I thought you were doing that, and particularly as more and more we share electronic medical records and we have longitudinal opportunities, how do we manage that med list? Folks go about it differently. One physician said, well, if they're not taking anymore, I delete that med and put it in my note. Another physician says, oh, I wouldn't do that. I would put a comment with that med and maybe do something else with it. So even how we manage and how we have our roles and our responsibilities, but really simplifying and standardizing those elements and eliminating unnecessary redundancies can go a long way. We have to work smarter, not harder, be more efficient. So once again, these guiding principles of really making the right thing to do the easiest, I think are helpful regardless of what process you might be tackling. Next slide, please. There are many quality improvement tools and techniques that are out there. There's failure mode effects analysis, there's lean, there's, you'll hear about Six Sigma, there's Plan, Do, Study, Act. There's so many of them. I personally like mixing and matching depending on the situation. There's also a lot more coming out about change management and how we do all this great stuff to design and pull things together, and we've analyzed. Now we're trying to implement, and we're like, well, we're implementing it. It's a great design. They will come. And so a lot more coming out about how we manage change. So this DMAIC process is just one example of a framework that you can utilize to just help, once again, put things in perspective. I find this to be a helpful framework. How am I defining the problem? Do I understand how big the problem is? Because then, you get, well, there's lots of issues. Show me the data. Why are we tackling this? What are some of those drivers? And I shared earlier, those drivers can be multifactorial. What do we want to do to fix that? And are we fixing the whole MedRec process, or are we maybe doing it in bite-sized chunks where we'll just look at the history, and then maybe we'll look at our education. Maybe we have some of those going on simultaneously. And then how do we really get this to be sustained? And looking at change management, is there's so much change going on in the healthcare industry, from payments to how we practice and everywhere in between. And then how we make sure that those are hardwired. So once again, this is just one example, and I'm sure you have others as well, but just to help it to put something so you have a framework to think through as your task as part of your TCPi work. Next slide, please. Here's an example of just developing a process map. One example, you can erase those and put those in for whatever thing that you're working on. Maybe in your area, you're only going to focus on how we obtain a history, how we gather that information for our patients, where in the workflow that happens, who's doing that. So maybe that's where your process map might take you. Flow charting those current workflows and identifying where there's opportunities is really the first and most important step. My biggest caution is not to bite off more than you can chew. There's nothing wrong in taking a very small piece and analyzing that and understanding and making those improvements, because as you do that and you build and progress, you're not only changing that one piece, but you're also helping change the culture and the framework and understanding about, how are we communicating? How are we going to measure in terms of our cost efficiencies? How are we doing other things that are part of that TCPi framework? And so this is just the first step in trying to understand that. And also just a big learning, try to not make it any more complicated and take things in manageable pieces. Next slide, please. So I mentioned earlier there's a lot of stuff going on. I mean, there is just a lot of things going on. I've been in healthcare for 25 years. I've worked in a variety of settings. I am a pharmacist by training, but I've also had training in public health, so now I'm looking at this in even more through a more global lens. I, again, think MedRec is really important, but I have colleagues that are working on other things as well, and they're like, it's not always about MedRec. And so how do we set the stage that we start thinking about all of these things that we're working on? How do we put it in a bundle? How do we develop some synergies so that we can work together? So for example, let's go to the next slide let's throw an example of how we might do this. So how do we bundle this? This is one example that I put together. We've been having a lot of conversations of who's working on what, who's doing what and where. And so you find out there's a lot of, it's like a Venn diagram, there's a lot of overlap. So I needed to put some things in perspective. So this was a slide that I came up to help me that I've now been sharing with others. So we've got care transitions. There's a variety of those happening. And this happens to be a bundled framework when you look at the inpatient side. You can do the same thing when you're looking at an ambulatory framework. We've got patients may come to the ED. They might get admitted. They have inter-hospital movement and transfers. Then the patient's discharged. Then there's a post-acute phase. So this is my world when I'm working in hospitals. Then I transitioned to the ambulatory space. So I developed another one of these for when I was working in that space and part of the TCPi to think about what did that transition look like. And then specifically for MedRec, where are those phases of medication management? How do those fit in with those care transitions? And then what are all the things, like what's the environmental scan of all the things that we're working on that are medication related, and how do we bundle those as part of this whole opportunity? I can give an example on an inpatient when I was doing work on inpatient MedRec. And nurses are working on a variety of different things. So they're doing hourly rounds. They're trying to capture their admission profile. I'm like, okay, let's walk through this. During an admission MedRec profile, the nurse is asking about a med history. The physician needed to do that as part of the H&P. We were getting a lot of feedback from patients that you guys don't know what's going on. Everybody's asking me the question 5, 6 times. Well, let's reframe that. Why can't we be a validation of what the doctor just collected? As a nurse, I'm validating with you, Mrs. Jones, as a patient. I want to make sure we didn't miss anything. But then let's look at it as an opportunity about what med changes are happening. What new antibiotics do we start because you have an infection? How other things do I need to communicate? What tests do you have going on? Now I'm developing their itinerary for the day. I want to talk about any side effects you might have. Now we're talking about communication about meds, which is part of our HCAPs and is part of other patient experiences. And then I'm going to write on the whiteboard to communicate about your pain scores and the new pain meds you have as PRN if you need to ask me for them. What's on your form? And then I'm going to come back in an hour and check on you and do some hourly rounds. So why can't we bundle some of those elements and not have them be, okay, I need your MedRec, and I need to come back and talk about this, and then how can we think a little bit differently to make these more efficient and to connect the dots? Next slide, please. So this is taking that prior slide. This is now looking at how we might build synergies. Now I talked to you about those 2 bookends, the discharge, post-discharge education phase. You can pull and pluck this piece out. You can look at that's one phase of the med management process I need to understand. And then what are some of those elements that are happening that we're looking at? Maybe we're going to focus on reducing readmissions. So now we have some interventions we might see right before the patient goes home. What's our bridging interventions? And then what's happening in the physician's offices? How are we communicating that? So what does the literature show? So once again, this is just a conceptual framework for how we might try to tackle a very complex problem and put it into pieces. And once again, because of a limit of time, we can have many calls and conferences, and I know you have some very well lined up. I think one before me was talking about MACRA and some of the elements about how we're being paid and how we need to think differently for quality. Well, how can we do our piece as clinicians to think through and build some of these synergies? So we just don't have time to not be efficient and not have good communication. So just this is once again a conceptual framework for you to think what might work in your setting. And I'm hoping the toolkit and the other pieces in there will help as well to help start to build these out as you're tackling these complex problems. Next slide, please. This is because I think a lot of the folks on the call are nurse practitioners or those that support nurse practitioners. We might have other providers. I know I labeled my presentation clinicians because there might be folks that are support. They might be pharmacists, physicians. I know there's a variety of folks that might call in or be around the table. So I want to take this from a clinical perspective. I know we look at MedRec oftentimes as a task, as steps, but maybe as a pharmacist in public health, I just have a broader view. think we have a lot of frustration because we feel like we should be at the end. You know, we've been talking about MedRec since 2005 when it became like a national patient safety goal, and we saw some things growing from the literature. For me personally, I think we're at the beginning. New information came out. I saw literature in the 80s talking about lack of concordance. So how can we take this to the next level? I think we're still kind of stuck a little bit at level 1, you know, collecting that list, trying to reconcile. That has a harm prevention strategy. I think that is so critically important. But how can we like dig a little bit deeper into medication reconciliation? What about reconciling that list to the patient's conditions? If we have a condition in OMAD, are they doing their diabetes with diet and exercise alone? If we have a NOMAD and we have a medication with no condition, why are they on that medication? Is there a way to streamline? Let's take reconciliation looking at their regimens compared to evidence-based. Is there a way to optimize therapies? Are we driving outcomes in that perspective? Are those therapies in the best in line with that patient and their best and unique needs? Are we adjusting the meds based on the characteristics? So just because we got the right list doesn't mean it's right for that patient. How can we look at that from a harm prevention strategy? And then once again, optimizing therapies to drive responses. So there's various levels than just comparing the list. I recently went to heard someone speak about laboratory. You know, how do we connect? How do we reconcile laboratory values with meds, with conditions? So we can take this to the nth degree, but once again, I don't want us to stop at just collecting a list and reconciling for harm. I think there's additional harm and outcome strategies that are just as important that may drive us to the next level as clinicians as we think of ways to better take care of our patients. So I'm going to end here. A lot of information, very high level, but I hope you were jotting down some notes and things that maybe we can talk about in the next maybe 15, 20 minutes we have together. And hopefully folks won't be bashful too to make comments that we can share and learn from each other as well, not just asking me a question and then not being able to dialogue a little bit, although I recognize we're a pretty big group. So I'll stop there and hand it back over to Cheryl for some Q&A.
Thank you so much, Kristine. Really appreciate you being on the line with us today and going through this content. I think it's really important content. I do just want to mention to people that we have been collecting your questions throughout the course of the webinar. Be sure that if there are additional questions, now would be the time to put them in. So you would just type it into the question tab. We do have a number of questions that have come through already. So I am going to pass this over to my colleague, Tiffany, and she will be reading out the questions, and we'll be doing the Q&A portion.
Awesome. Thanks, Cheryl. And thank you again, Kristine. We really appreciate you taking the time to present not only your research, but also discussing how it contributes to TCPi and just improving patient safety in the broader context. So a number of questions came in, and I'll just go ahead and start from the top. So the first question that we have came in from Kathleen, and it was more of an observation, and she wanted to get your opinion. She says that in her experience, one of the best ways to reconcile medicines is asking the patients to, quote, bag all the medications they use and take on a regular ongoing basis, including herbal supplements, et cetera, and then bring them in with each visit. Bring them in with each visit. For instance, they found a patient that was asking, that was taking blood pressure medication, including the same med each time the dose was increased. In general, what's your opinion of that, Kristine, as far as asking patients to bag and bring in all of their medications as a form of MedRec?
I personally think that is a phenomenal idea. Now, others might disagree because of a time restraint. The example that you gave about something you found is exactly why. We also actually, there was a patient that came in who had blood pressure kept dropping and they kept fainting, and they didn't know why. We're running all these tests, nothing was showing anything. So the pharmacist went to validate one of their meds because they wanted to take their own meds, and it turned out the meds in the bottle was atenolol, and it was not, I think it might have been a synthroid or something like that. It was completely different. So as soon as we found that out, discovery solved, patient was discharged. So those bottles can be really important. I also think it's important because then you can help the patient in managing their medications in a way that's appropriate for them. So if I say take it in the morning, I've had patients work nights, and they're like, you know, my morning is not AM, my morning is PM. Help me rethink that. And also, you know, is it also a way to say, Mrs. Jones, you're not taking any of these, let's do something with them. And I know patients like to hoard because of money and things like that, but then that also adds an opportunity to confuse what meds they might have or not. So I am a huge proponent of the bag and bring. I know there's some new payment structures that are exploring paying for this, and there's some MTM programs that do. So I would never want to not encourage that. If you can't do it in the office setting or there's not enough time, there's always, that's a great way from a community opportunity to bring a bag and to work with the community in order to get some excitement around this and to help patients manage a list. So I probably went on with a longer answer than you wanted, but I think that was a significant finding in our match work about the list and the bottles. You know, we say that, but we actually found it made a difference. So, so I'm just a bit more passionate about that. I just think that it's a timing issue, so we just need to think creatively about how we work through that process. And maybe it's not every visit. Maybe it's we do a really complex, you know, comprehensive process, and then maybe it's a yearly thing, maybe it's quarterly, or maybe for that particular patient it does need to be with every visit depending on their complexities. So great question. Thank you.
Great. Thanks, Kristine. The next question comes from Lori. She's asking if you could recommend, or perhaps within the template, is there a recommended template for at-home medication list or for patients?
Another great question. So there is not, and there are a ton out there. Some are much better than others. So when we do have some samples in our toolkit, I've actually seen some more recent samples that I really like, and each patient does it a little differently. I will say, and I can't say I know where this went, but when MedRec, when we first started back in the 2000s, South Carolina actually tried to have a statewide initiative to come up with a standardized med list. So that, and I mean, they had all professional societies and things sign on to say, this is the list. And it went through a variety of folks to look at that. So there was consistency across the state in folks presenting. So I do agree that I think helping put it in a framework, there's a lot out there and patients can find it. I think it's a matter of what works best for the patient, and then how we utilize that list in our conversations is probably the most important. But I do like the fact of a templated process that's workable and manageable, because I do think sometimes patients pull stuff off and it's not as helpful. So I would be a proponent of that. I can't say I know whatever happened to the South Carolina approach. I thought it was very novel and a phenomenal way to approach it. But once again, I just think, regardless of what the list is, that we're sending the message that it's not just about your insurance card, it's not just about your license. We really think this list is important, and if the patient starts to hear that, I think that will also start to stimulate some more opportunities for their involvement. Because I've had patients tell me, why are you asking me this? It's in your computer. I'm like, well, it's really not. And so I don't know that they really understand, too, the complexities. So yes, I agree with a template. There's a variety out there. I found some that are much better than others. And then I don't know if anybody has any information about South Carolina. It would be great to know how that worked or how much traction they got on that. So I don't know if those are helpful, but just some examples of what my feelings are. And then, yes, I think a template is helpful to put some framework for the patient as well.
Awesome. And we brought up the screen here that includes the link to where attendees can view the toolkit, if there are any templates within there. Also, if any of the attendees on the line have come across a great template that has worked in practices, we encourage you. You can, if you want to send them to myself, my email address will be at the end of the presentation, and I'm more than happy to share them with all of the attendees. That'd be great.
And even like beyond just the med list, I mean, if you look back at the tips and tricks, we had like, well, you know, Mrs. Jones, who prescribes your medications for you? That also, oh yeah, I forgot Dr. So-and-so gives me my eye drops. And so, you know, so there's where some of the variability in the template, you know, comes in, do we want the list of physicians? How do we communicate? So if anybody does have some great lists, I'd love to see them too, or work that you've done through the TCPi, because I'm here to learn as well. I sure don't have all the answers, but that would be great. That's a great idea, Tiffany. Thank you.
Awesome, awesome. I think that's what we all love about presentations like this. They kind of morph into like these community of practice sessions. So awesome. So the next question is from Tanya. Tanya makes an observation and she wants to hear your thoughts. Hospitalizations are the biggest problem. Routine medications changed due to formulary restrictions within the hospital. Reconciliation of medications prior to discharge resume, continue on to the home medications to cut down on confusion and medication adherence issues. What are your thoughts on this?
150% agree. And it's interesting because doing this for a long time, well, why aren't we communicating? We don't appreciate. The hospitals don't appreciate, and I'm one of them because I worked in the hospital for a long time. Unless we get feedback from the community, there gets a sense of comfort that how we discharge patients, everything must be okay. It's maybe the patient's just confused. And so unless we get that feedback from the community, and I think our changes in how we're reimbursed might start those conversations a bit sooner. I think as a hospital, we don't always appreciate how much back-end work there is. There's also some patient elements as well. Working once I started in the TCPi from the ambulatory space, a lot of patients don't feel comfortable with the changes because I just saw that provider for a short period of time. I want to make sure that I follow up with, my doctor I've been going to for 20 years, so I'm just going to go back and start everything I was doing, and then I'll talk with them in a week when I have my follow-up appointment. So you also have some patients are reluctant to make some of those changes. So it goes back to that multifactorial slide. There's formulary issues. There's issues with stopping and starting meds. Where we came from, we actually put pharmacists in the ICU to do the transfer med rec because we found that was a huge opportunity for when meds are changed. Things are often then on hold. We have drips. We have other elements. And so that was a way to start the process of restarting some of these home meds and readjusting those to help in the discharge process. So that's one example of tackling that. The other example is feedback and is community partners working with hospitals that maybe discharge a lot of your patients. And then we also need to think about how are we messaging to patients as they're leaving and getting ready for the next provider of care. And that's where to the other question about bringing in bottles. I know one hospital that had patients bring in their bottles and did that comparison to prepare them to go home. If you look at Project Red, another ARC-funded study that did a ton about discharge, they have a phenomenal toolkit, much more specific in regards to these elements, and you might find great information there as well. But once again, it boils down to time. And so I think we just need to think more efficiently and creatively. Would you rather spend this time up front or handle having to address a medication error or having to address something in our offices? So I think that's where some of those conversations need to happen. The other thing, too, is when the patients are in the waiting room, can we use that as an opportunity to give them a list, have them update it, maybe bring their bottles and look at that to get some upfront work to help in our efficiencies. So those are just some examples and some comments, and I hope that's helpful. And if there's other follow-up questions, I'm happy to take those, too.
Thanks, Kristine. It's Cheryl. I'm back on the line. We're running a little short on time. I wanted to address two of the questions that came up. So Angela was asking about this presentation, feeling a little bit more about the inpatient setting and physicians versus outpatient and nurse practitioners. Yeah. So I did just want to mention that all of the things that we're talking about in the tools are really provider use. So not intentional to not specifically name NPs throughout the presentation, but I think the understanding is that these could be used both in inpatient and
absolutely, and I'm so sorry for that. And I think from the prior question, it doesn't matter where you work. These are interchangeable, and that's why the conceptual framework is important as a nurse practitioner. And whatever your role and responsibility is to think about what is that practice that I need to address? How does MedRec fit in? What kind of patients am I seeing that I need to tailor this to? So it doesn't matter the tips and tricks for getting history if you're in the hospital or if you're in an ambulatory space. For the flow chart, it doesn't matter what that flow is regardless of where you work. We may have some folks that work with nursing homes. Another thing, how do we flow that? How do we partner? So that's where these techniques come in. It's really about the conceptual framework and using that in order to make what makes sense in your workspace. And these were just purely examples of that. And I'm happy to pull out some that we recently worked on in the ambulatory space as well in putting these together. And I think that's why webinars are so tough, because there's a variety of folks in a variety of settings. But regardless of where you work as a nurse practitioner, I'm hopeful that you'll find these are tailorable, that are able to be tailored, and that the conceptual framework can be used to fit those within your own setting.
Thank you so much, Kristine. Just for the sake of time, I'm going to go ahead and move us along. This next question, Cheryl, would you mind answering this next question? It comes from Kita. I hope I'm pronouncing that correctly. My apologies if I'm not. Kita is asking, have you seen more technological changes in regards to MedRec? For example, connecting Walgreens or CVS or your local pharmacy's medication lists being set to primary care EMR systems.
So the reason that's being bounced back to me is that I did work in a retail setting for a number of years. One of the beauties of retail health, particularly with CVS, I'm more familiar with that pharmacy chain, is they use Allscripts. So medication reconciliation happens at every patient visit. Recently I worked on a CMS initiative developing an outpatient. It can be used both outpatient and inpatient flow chart for MedRec, which we will be sending out after the presentation to all of the participants, which will give you a little bit of a template and something that you can use. My recommendation to CMS was having better partnerships between the pharmacy chains and physician offices so that we would be better able to transfer that information back and forth, and also promoting medication reconciliation at every single touch point with patients, regardless of the provider that might be doing that, whether it was an MA or a nurse or an NP or a physician. So really the key point is reconciling meds at every single visit.
And that just Cheryl, just really quickly, I think that's where the levels of medication reconciliation and where our partnerships between the pharmacy chains and nurse practitioners, also thinking about what conditions are we treating, just some of that information can be very valuable. And I agree, I think we have a lot of work to help build those partnerships because those community partnerships in our pharmacy partners, I think, are really important. And just that's one example of the reconciliation of including conditions can also help as a part of reconciliation.
Great, thank you. So just as a point of note, a couple of questions are rolling in asking about the slide deck, and if the slide deck is going to be made available to attendees right now. So if you look onto your pane there, your window pane on the side, there's going to be a drop-down menu for handouts. If you click there, you'll see that there's a PDF version of the slide deck available to all attendees for download. If you have any difficulties, go ahead and reach out to me. Again, my email will be made available at the end. So we probably only have time for maybe about 2 to 3 more questions, Kristine. The next question comes from Sandra, and she is asking, where do you account or consider genetic profile regarding MedRec, for example, genetic tailoring medications? So a very specific question, but hopefully you can answer it fairly concisely.
You know, that is a great question. It's on my radar because that is, and that's another reason I pulled up the levels of reconciliation as an NP, as nurse practitioners. You're just at a much higher level of work with the patients. And so that piece in terms of conditions and tailored medications, all I'm going to say is I think MedRec is going to get more complicated instead of easier for the genetic tailoring. So if we can't even figure out what they're on now, and then we add in even more specialized therapies to help drive patient care, this then puts MedRec at an even greater need. So I'll just leave it at that. I think this has a huge piece, and I think we need to be ready for it with our changing research. But once again, it's, for me personally, it speaks to why we need to have a look at the higher levels of remediation in order to be ready for this when it starts to become more of a reality.
Great, thank you. So this next question that we have has come up a couple of times, but where or how does culturally specific care interface with medication reconciliation?
Boy, you guys are really touching on the tough ones. You know what? That's where I think when we talk about patient-centeredness and patient engagement, this is where I think the rubber meets the road. A lot of patients might not feel comfortable telling you about a medication, that the language, all those other things. I think that might be in itself, and not to throw things back at Cheryl and Tiffany, but that in itself I think would be a phenomenal presentation to think about just our changing patient populations and how we address some of those elements. They have to be part of that multifactorial view. We can't just be like, well, every single patient can't afford their meds, you know, and that must be why they're not taking them. We need to understand the reasons and create that transparency and open conversation. So yes, it fits in. It's important. It must be recognized. But I don't know, in the interest of time, that I have all the right answers, or that I would be the right person to talk about how we address the specific elements that would be really important to pull out in a presentation.
Great, thank you. So one or two more questions. Do you think that expanding interoperability of EHRs will eventually resolve this issue, or do you at least see some mitigation of the issue?
No, I don't think it's going to resolve it entirely. Cheryl talked about all scripts, so you have a way to look at what was filled, like their fill history. So you have that. You have old records. You have the patient. Sometimes I think as you get more information, it becomes even more confusing because you have more discordance. And I don't know yet, and this is as nurse practitioners, and you're working in the offices, how are we managing that medication list? Do you manage it the same way as the physician or as another nurse practitioner? How do we handle when a patient's taking meds differently than prescribed? Where do we document that? Do we leave it on the list? Does someone take it off the list? So I think until we get some concrete kind of consistency of how we manage meds, what if I'm in the view only? And now I have a linkage to view only, but I see that view and I know it's completely incorrect. How do I change that source? So I think technology is handling a lot of wonderful elements, but then I think there's other things it's uncovering that we are going to need to look at. And even in your own clinic settings, you have to come up with consistency about how you handle a medication list for different scenarios. That would be a step in helping in our interoperability of how because we can share, but then what are we sharing, I think, is the next step. So, so that's why I answered no.
Hi,
but I would never go back to paper. Let me just throw that out there.
Thank you. I just wanted to say that we've gotten a lot of thank yous for the great work, and that the dialogue between the provider and the patient is one of the many key points here, and that we need to understand and make ourselves as NPs part of that conversation. I would encourage all of you to look at whatever you are doing or what you have in place right now as kind of like a little mini study within your practice settings to look at medication reconciliation and how it's being done, and I would below of how that works or does not work. We would be very interested in hearing back from you as you do this and we move this conversation forward. We're about at the end of our time. Many people have thanked us for the work. I think the work is really incumbent upon us as nurse practitioners throughout the U.S. to continue to open this dialogue and conversation. If you have additional questions or you would want to get feedback to us about this, Tiffany would be the point person, and her email is listed there for everyone's use. And I also just wanted to mention real quickly that we will be having another webinar will be coming up next month. And we'll be talking about radiology and imaging. I'm talking about practice tools for clinicians, specifically nurse practitioners. So I know this is an area probably near and dear to many of you. It's something we can always use additional information on. So this will be the day and the time for our next webinar. I thank you for attending, and please also, you can send us your feedback with any requests that you might have for additional topics. And once we finish this today, you will be getting an evaluation and a survey after the webinar is completed. We really appreciate your feedback. We want to make these webinars as meaningful as possible for all of you, so please take the time to fill that out. We do go through them, we read your feedback, and we really look forward to having you again on a future webinar.
Thanks, Kristine.
Thank you,
absolutely. And I forgot to say, the Gallup poll says nurses are the #1 most trusted profession. So you guys are already have set the stage. So, and pharmacists are #2. So I know this is a lot of great work, and thank you for all that you do as well for the patients.
Thank you. Take care, everyone. The webinar's ended.